Awesome. Thank you. Several years in, Quentin asks me every morning, "Where's your tie?" And I tell him, "Quentin, I will not put on a tie for this or anything." So I apologize if you're offended by that. Um, I'll let you tell them that. Okay, I have 30 minutes to go through a very dense slide deck here. So I'm going to try to keep it interesting. I have no disclosures. I am going to assault your brains with a lot of EP this morning. So hopefully you guys are ready. We're going to put your brain into submission and it's going to be a little crash course in EP. So my objectives today. I don't know why I picked 5 arrhythmias as I was finishing my slide deck at 11 o'clock last night, but we're going to cover atrial fibrillation and flutter. We're going to blow through that because we just did that last year. We're going to cover SVT, different types of SVTs. We're going to cover VTVF, ventricular tachycardia, ventricular fibrillation, idiopathic PVCs, and then bradycardia and heart block. So it's pretty dense, but let's see if we can try to make sense of these things. And my job is, not just to have you memorize a bunch of things. Hopefully, you kind of go through the mechanisms and explain why things are the way they are and why we fix them the way we do. So, let's talk about AFib. We know what this is. It's the most common arrhythmia that we see. Incidence keeps going up. It's this irregular, chaotic activity that happens in the right and the left atrium. It causes several issues: cardiomyopathy, heart failure, symptoms, obviously stroke risk. And once again, as I said, I'm going to blow through that. Let's talk about atrial flutter. This doesn't get enough of a recognition. Atrial flutter and atrial fibrillation are close cousins of each other. What we're going to talk about today is typical atrial flutter. And this is an arrhythmia that usually originates or does originate in the right atrium, and it involves very specific structures. It involves the inferior vena cava, and it involves the tissue between the inferior vena cava and the tricuspid valve. And this is the most common type of flutter. Now, there's something called atypical flutter, which involves any other cardiac tissue in the atrium, whether it's the right atrium or the left atrium. We're not going to talk about that. We could spend 45 minutes just talking about typical and atypical flutter. Most of what we see is typical flutter, and that's what we're going to focus on. And this is, the typical sawtooth pattern that you see. And this is usually in the inferior leads. So that's lead 2, lead 3, and lead AVF. Now, sometimes, someone will bring me up an EKG and show me this sawtooth looking thing in lead V1. That's not typical flutter. When we're talking about a sawtooth pattern and typical flutter, we're talking about the inferior leads. AFib and atrial flutter coexist a lot. This is the whole reason I'm even bringing this up, because clinically this is relevant and this comes up frequently. So this was published in Europace last year. It's a retrospective review, and they looked at it. If you came in with atrial flutter, what percentage of those patients also have atrial fibrillation? And if you came in with atrial fibrillation, what percentage of those patients also have atrial flutter? Because mechanistically, they're two different things, even though we treat it the same. 1/5 of AFib patients had atrial flutter. So 1 in 5 patients that had AFib also had atrial flutter. And, it's important for me because if we're taking someone for an ablation and if they have flutter, it makes sense to ablate both of those arrhythmias at the same time. But the converse actually is much more important. 80% of atrial flutter patients will experience atrial fibrillation at some point. And that's troubling. I'll tell you why as we go along. So what is atrial flutter? As I said, this is a circuit that exists purely in the right atrium. Typical atrial flutter. I want to keep clarifying that. Along the way here, I'm going to give you several tips. If you don't remember anything, just remember the tips I give you. Typical atrial flutter involves right atrium, and it involves the isthmus that I mentioned to you, the tissue that exists between the inferior vena cava and the tricuspid valve. And when we do the ablation, that tissue is right down there at the X, and that's how we interrupt this electrical circuit. As opposed to atrial fibrillation, which usually starts in the left atrium, and it's just this chaotic activity. It's fibrillating atria. The atria are going 400 beats a minute, and the way you fix that is you ablate the pulmonary veins. Remember that from last year? So we isolate the electrically isolate the pulmonary veins. So this is just a schematic with the right atrium kind of cut open, drawn on it, and there's a circuit that you see going in the right atrium. And when we do an ablation, we place this catheter and we cauterize this tissue right here. And what we're doing is we're causing electrical block. Everything in the heart muscle does not conduct at a uniform velocity. That's the other tip today. Atrial tissue conducts at different velocities depending on what you're looking at. So the tissue in the isthmus that I pointed out there conducts slower than tissue in the rest of the atrium. AV node conducts at a different velocity than atrial tissue and ventricular tissue conducts. The His-Purkinje system conducts at a different velocity. So the whole reason this circuit gets set up is because of slow conduction in this specific region, the cavo-tricuspid isthmus. Why do we care about this? If you do a flutter ablation on someone, can you stop their blood thinner? Are they good to go for the rest of their life? Hard to know. This is a challenge. We don't have a clear answer on this, but the incidence of atrial fibrillation after you've done a typical flutter ablation on someone, 50 to 60% of those people will develop atrial fibrillation in the next 5 years. And there are certain groups, the Penn group says you should always be looking for atrial fibrillation in these patients. I'm very aggressive for looking for atrial fibrillation in patients who've had atrial flutter. They ask me, hey, you fixed my flutter. The flutter ablation generally is a curative procedure. Remember, atrial fibrillation ablation is not a curative procedure. That can come back. But they ask me, hey, can I stop my anticoagulation? And we have to have a conversation about, hey, here's the risk of having atrial fibrillation. Get a wearable. Let's put it on a loop recorder or keep taking the blood thinner and just give this time and see what happens. So we've covered typical flutter. We're not going to cover atypical flutter. The takeaway from this is cardiac tissue does not conduct at a uniform velocity. The circuit gets set up in the right atrium between the IVC and the tricuspid valve because of slowed conduction in that area, and the ablation identifies that. We did not go much into atypical flutter. How do you treat it? As I said, management is similar, rate control versus rhythm control, stuff we talked about last year, AV nodal agents, antiarrhythmic agents, amiodarone, sotalol, flecainide, whatever you have, anticoagulation for stroke prophylaxis, and symptom management, making sure they don't develop heart failure, LV dysfunction, et cetera, et cetera. Moving on, SVT. This is going to be dense, so get ready. So SVT is an umbrella term under which we have three main categories. AVNRT, which is what 65% of patients will have. This is called atrioventricular nodal reentrant tachycardia. There's a reason I highlighted or capitalized nodal on there. We'll talk about that. The second most common is something called AVRT. This is atrioventricular reentrant tachycardia. This involves an accessory pathway. So this is your WPW, or what we call an accessory pathway. And the least common is something called an atrial tachycardia, which is what we'll see in about 10% of patients. You guys can hear me okay? So 65% of all SVT is AVNRT. So if anyone ever gives you a hard time and wants you to identify an EKG with a narrow complex tachycardia, you'll be right 2 out of 3 times if you said this is AVNRT. This is because of dual AV node physiology, which 30% of us have. So I don't know how many people we have in the room, but a third of us have dual AV node physiology. Some data says it's even 40%. And this usually responds very well to adenosine or metoprolol and cardizem. You rarely have to use antiarrhythmic medications for this, such as sotalol, flecainide, and amiodarone. And actually, ablation is a curative procedure and essentially the standard of care, unless the patient prefers not to have a procedure done, or, you know, there are other reasons that get in the way of procedurally fixing this. So what the heck is this dual AV node physiology? All right, get your brains ready. So here's the all-seeing eye of UPMC at the steel tower. No, I'm just kidding. This is the AV node, okay? This is a very poor rendition of the AV node. This is a simplified version of the AV node. AV node looks nothing like this in the heart. It's this just broad area of cardiac tissue that conducts at different velocities. But we're going to simplify it. We're going to make it look like a simple structure around AV node. It has what we call a fast pathway. This is the pathway that conducts very efficiently, very quickly. So when you have a sinus beat, and I'm sorry, there's also a slow pathway that exists in parallel, and those squiggly lines are supposed to represent that the electrical conduction over that pathway occurs much more slowly. So when you have a sinus event that comes in, what is it going to prefer? It's going to prefer the fast pathway, right? Because that electrical conduction goes down much quicker down the pathway that's available. And if you have a PAC that comes in, it's going to block in that fast pathway because the sinus beat had just activated that, but the slow pathway, which was not engaged, is available for conduction, and the PAC is going to go down the slow pathway. And this is, if you understand this, this is called reentry. You understand 80% of what I do. So what happens here is, I'm going to use the screen on this side, is because the sinus beat had just gone down the fast pathway. When this PAC comes in, remember, cardiac tissue depolarizes and repolarizes. If it hasn't repolarized, it cannot depolarize again. So when this PAC comes in, it is unable to go down this pathway because this was just activated by the previous sinus beat. But this pathway is available, so it goes down the slow pathway. Now, when it comes down here, the fast pathway has now repolarized. It's had enough time to be activated again. And, this is just dumb electrical tissue. There's no way it has to only conduct in this direction. It can conduct in this direction. So this creates what we call reentry. This is a circuit that ends up developing in the region of the AV node where the electrical wavefront is just going in a circle, going up to the atrium, going down to the ventricle, and that's what's causing AV and RT. And what you do for this is you ablate it. You cauterize the slow pathway, and what you've done now is when a PAC comes in, it doesn't have access to that slow pathway. All it can do is either go down the fast pathway, create a QRS, or it just blocks, and you see a blocked PAC on an EKG. So this is everything that we're going to talk about today when I talked about assaulting your brain. So hopefully I've clarified what AV and RT is. How do we treat it? Medications work really well. Ablations are usually a curative procedure. Let's talk about AVRT. So AVRT involves an accessory pathway. So that means a bypass tract. The most common form of this you've heard is the WPW tract, but that's actually the least common form. Most of the bypass tracts, you don't even see it on an EKG because it's what we call a concealed bypass tract. So the normal conduction in the heart, so there's the bypass tract. Normal conduction in the heart comes from the sinus node, goes down the AV node, goes into the right ventricle and the left ventricle. If you have a bypass tract, that's short-circuiting that conduction, and actually that wavefront is going down the bypass tract also because it's electrically active tissue. And what happens is these two wavefronts collide and nothing happens, right? The left ventricle got activated. The only thing you see is a delta wave. And why do you get a delta wave? Because this electrical wavefront, instead of going down the AV node, going down the His-Purkinje system, the right bundle and the left bundle, which is what gives you a narrow QRS, this electrical wavefront actually also went down this bypass tract and prematurely activated the left ventricle. Remember, anytime the left ventricle gets activated by myocyte to myocyte conduction, meaning this is not going down the His-Purkinje system. This is cellular activation, which is what ventricular tachycardia is, right? It's coming from somewhere down here, and it's myocyte to myocyte conduction. That QRS is wide because it's very inefficient conduction. It takes the heart muscle a long time to generate that QRS, and that's why you end up with a delta wave. This is premature activation of the myocardium that shouldn't be there, right? So in most cases, this collides, nothing happens. And as I said, this actually, WPW is the lesser common version. Most of the times the activation, the electrical wavefront goes up this way, and you'll never see that on an EKG because you're actually engaging the normal His-Purkinje system. So the only way to know that is doing an EP study, okay? And there's the reference for that, my iPad. Took me a long time to figure out how to show this until I said, you know what, I'm just gonna draw this. So now let's look at what happens with a bypass tract. You have a PAC, and if the timing of everything is just perfect, what's going to happen is this PAC is going to block in the bypass tract, but it will have access to the AV node. And you've essentially created reentry, what we saw at a very small AV nodal level, at a much macro level. Now this is involving the AV node. The electrical wavefront is going down the AV node, going up the bypass tract, and you've created another reentrant circuit. And that's what AVRT is. How do you fix this? You can give the medications or you ablate it. You put a catheter on the bypass tract, you burn it, and once again, you have the PAC does not have access to that pathway. The other way this could happen, real quick question. Will this tachycardia, the one that went down the AV node and went up the pathway, will that be a narrow QRS tachycardia or a wide QRS tachycardia? It'll be narrow, awesome, because it's going down the AV node, it's going down the His-Purkinje system, which is your normal electrical activation, right? So the other scenario is this PAC blocks in the AV node, but now goes down the accessory pathway, and the reentry goes other way. So we call this orthodromic and antidromic reentry. Once again, the fix is the same. You fix the pathway. Will this be a narrow or a wide complex tachycardia? Wide, because it's not going down the AV node anymore. The circuit is going in the opposite direction down the pathway, which is going to activate the ventricle. ventricle first. So why does that matter? This is why it matters. Well, it matters for ablation purposes and what else you do. What is this? Can anyone identify this EKG? I'll give you 15 seconds. So you see a very bizarre wide QRS, but it's very irregular. So it's probably not ventricular tachycardia. This is what we call pre-excited atrial fibrillation. This is the other tip. Do not ever, ever, ever get this wrong. If you're in the ER, if you're in the ICUs, if you're on the floors managing cardiac patients, because the treatment for this the incorrect treatment for this could kill the patient. So what is pre-excited AFib? That means that you're in atrial fibrillation, but you also have an accessory pathway. And if you give this patient AV nodal agents, if you give them metoprolol, cardizem, digoxin, anything that blocks conduction down the AV node, because let's say they come in with that EKG I showed you, their heart rate's really fast, they're in AFib. If you block conduction down the AFib, the only path for that atrial fibrillation to go down is the bypass tract. So now all of that electrical wavefront is going down the bypass tract. What's the problem with that? What's the rate of the atrium during AFib? 400 to 600 beats a minute. Now you've created AFib into VFib because now the ventricles are going 400 to 600 beats a minute. So you never, ever, ever, ever give this patient AV nodal agents or digoxin. You will kill them. The treatment of choice, if you ever are in a bind, is IV procainamide, IV ibutylide, amiodarone as a last resort, or you just have to cardiovert them if things are really bad. All right, atrial tachycardia, the least likely SVT you'll see, 1 in 10. The most problematic from an ablation standpoint, because these can be very notoriously difficult to bring out in the lab, to unmask in the lab, to map it, to see where they're coming from, because it's difficult to sustain these tachycardias sometimes. It can come from anywhere. It can come from the right atrium. It can come from the left atrium. It comes from the SVC, the tricuspid valve, the mitral valve, the appendage, the pulmonary veins, the crista terminalis, which is a structure in the right atrium, the ostium of the coronary sinus. The one I want to highlight is something called a parahisian atrial tachycardia, just so that you've heard about it. I've done probably 5 of these in 10 years. We don't see a lot, but this is an atrial tachycardia that originates very close to your normal, your His, which is the structure below the AV node. If you're not careful and you ablate the His or the AV node, this patient goes into complete heart block and they need a pacemaker. All right, done with that. Moving on, ventricular tachycardia. So moving on to the bottom chambers. 90% of ventricular tachycardia is a problem. It's because of structural heart disease. Could be a life-threatening condition. It's because you had a previous MI. It's because you have a history of non-ischemic cardiomyopathy. You had myocarditis at some point. You have HOCM. Dr. Jeffrey's going to talk to us about that. You've had sarcoidosis. You have arrhythmogenic right ventricular cardiomyopathy. There's a host of structural things that can happen to the heart muscle that leave behind scarring. The reason ventricular tachycardia happens is because you have scarring in the heart muscle. 10% are idiopathic and benign. We'll talk about that. If someone said, this is the next tip, here is a patient with a wide complex rhythm, what is this rhythm? And if you said ventricular tachycardia, you'd be correct 4 out of 5 times. So if anyone ever wants you to guess or ever make an educated guess on a wide complex tachycardia, if that person has a known history of structural heart disease, CAD, low EF, whatever, 90% of the time, 9 out of 10 patients will have ventricular tachycardia. The caveats, if they're less than the age of 35, unlikely, can still be ventricular tachycardia, but think SVT with aberrancy, or think WPW. Could they have WPW? And always look at the baseline EKG. You know, if an 80-year-old with coronary disease comes in with a wide complex rhythm, but they have a right bundle branch at baseline or a left bundle branch at baseline, and the wide complex rhythm looks similar to that, then it's probably not ventricular tachycardia. It's just that they have wide complex to begin with. Sorry, not good pictures, but have to show pictures of VT. It's just wide complex tachycardia. It's monomorphic, meaning all QRSs look the same. It's fast. It can be hemodynamically unstable. This is actually a VT tracing from a life vest. You know, we see this all over the place. So this patient goes into ventricular tachycardia, gets shocked by his life vest. So just kind of some interesting tracings. This is a 76-year-old patient that presents with this wide complex tachycardia. In the ER, we were consulted, and there are several algorithms which we're not going to go through that we could discuss for what is this ventricular tachycardia? Is this supraventricular tachycardia? We don't know, but honestly, you can't talk about ventricular tachycardia without talking about pornography. So Potter Stewart was the Chief Justice in the 60s and was asked to opine on a case involving pornography. And the gist was, he says, I know it when I see it. So Ventricular tachycardia, in this case, was it a case of I know it when I see it? Yes. It doesn't look like ventricular tachycardia, but this woman also had a normal ejection fraction. She was hemodynamically stable with this. She has no known history of coronary disease. Her hemoglobin was 5, her potassium was 3, her mag was 1. She had several other things that were going on, and this was either flutter with a rapid rate or sinus tach or who knows what it was. So not VT because I know it when I see it. So workup is complex. It's multidisciplinary. You need echoes and cath and cardiac MRI and maybe genetic testing. Treatment complex, acute versus long term. It's beta blockers, it's amiodarone and procainamide, and shocking them into rhythm, and putting defibrillators or offering VT ablation. Patients rarely, but sometimes can be asymptomatic with this. Most of the times they'll have some symptoms, could be mild, just chest pain, some lightheadedness, to profound, pressure in the 60s, feeling really poorly, to just all-out cardiac arrest. And just because this is what I do, ablation is an option for these patients. It's not the only option. They should have a defibrillator. It's the 90% that we talked about, not the 10% idiopathic patients. You identify the scar on the left side of the screen is a map we've created. That's all scarring. Purple on this map is healthy. Red is dead cardiac tissue. This is the left ventricle, I'm sorry. And the tissue in the circle is all scarring. You put a catheter there. You can imagine how this scar can make electrical wavefronts go just absolutely haywire, and they're causing ventricular tachycardia. You identify the scar, you ablate it. 3B is ventricular fibrillation. I don't think we need to spend much time on this. This is death. I mean, ventricular tachycardia can be deadly. This is certain death. It's caused by ischemia. It's caused by scar in the heart muscle from prior injury and insult. It's electrical abnormalities, electrolyte abnormalities. It's drugs, whether it's recreational, that's drugs that we're prescribing them. It could be genetics, channelopathies, hypertrophic cardiomyopathy. I just want to give a quick shout out to channelopathies. This is something that I spend a lot of time thinking about when patients come in with this. There are several things that can predispose you to having ventricular fibrillation, not because you have coronary disease, not because you have hypertrophic cardiomyopathy. Things like long QT syndrome, short QT syndrome, Brugada syndrome, CPVT, early repolarization syndrome, just so that you've heard it once. Couple of fun ventricular tachycardia EKG, fibrillation EKGs. Yes, I just did use fun and ventricular fibrillation together. You can do it when I do what I do. So this is interesting because this patient was getting an EKG, and as they're getting the EKG, they go into ventricular fibrillation. But the more interesting part was they left the EKG machine on. This was a picture a friend sent me. That's why it looks funny. And continued to get an EKG because the patient was in ventricular fibrillation, and the patient did not have a VAD in place. We're going to learn about VADs later. So the patient did fine. This is This is a 19-year-old kid who collapsed on the basketball court. This is my plug for AEDs, especially at places where kids are playing sports. The patient's in ventricular fibrillation, gets shocked and did fine. This is a 16-year-old kid playing football. Patient goes into VF. It's fine VF on the top, but gets shocked, goes into asystole, but does fine and did okay. So AEDs save lives. Next one, idiopathic PVCs. Let's blow through this real quick. This is a 10% where it can be benign. Instead of boring you with details, let's talk about a case. This is from a few years ago, but I do this about 20 to 30 times a year. I'll get sent someone with this EKG picked up to have PVCs. They're either symptomatic or asymptomatic. PVC burden was about 16% on their Holter monitor. This patient has had an EF of 25 to 30%. She is on guideline-directed medical therapy. Her cath was normal. Her cardiac MRI is normal. Her repeat echo shows her EF is still 25 to 30%. She gets sent to me for an ICD. Did I put in an ICD? No, I did not put an ICD. Do not ignore PVCs. Do not ignore frequent PVCs. Do not ignore frequent monomorphic PVCs. If the PVCs are of the same morphology, do not ignore PVCs that are high burden. Anything over 15% is what we really worry about. 20, 30, 40% is very high. Worry about those patients that they're going to develop a cardiomyopathy and know that that cardiomyopathy can be reversible. So I did not implant an ICD. I took her for an ablation. Most PVCs, as I said, are benign unless they end up causing cardiomyopathy, then it's a problem. And in a normal heart, that's why I said the cath was fine, the cardiac MRI was fine, the echo was fine, the baseline EKG looked okay. In a normal heart, most commonly PVCs come from very well-defined areas of the heart muscle. We can look at the EKG, we can make an educated guess for where we think these PVCs are coming from. We map them, we ablate them, and once again, this is a potentially reversible cause of cardiomyopathy. You can talk drugs. I don't want to push ablations on everyone. Drugs have variable success for arrhythmias in general. Generally speaking, I tell patients 40 to 50% likelihood that flecainide, sotalol, amiodarone, ticagrelor will work for rhythm management, whether it's atrial or ventricular. And you got to take a medication, and you got to worry about the side effect profiles, et cetera, et cetera. So several algorithms out there for where we think the PVCs are coming from. I'm not going to bore you with the details, but the only thing is you got to put them on the table of truth, and you take them to the lab and you map this. You see where they're coming from. This was the PVC ablation for that specific patient. That's the aortic valve you're looking at. There's the catheter sitting in there. You see the little green thing. That's us mapping it. It was coming from the aortic valve. We cauterized it. Her PVCs never came back. This was a map of us ablating the PVCs. Her EF normalized. She had rare PVCs. We stopped all her medications. She didn't get an ICD, and life is good. All right, I think I have 6 minutes to go through bradycardia, and this is going to be rough. So sinus bradycardia, the most common one you're going to see. Sinus arrest. The sinus node has just stopped working. Remember, sinus node is your normal pacemaker, and now you're relying on a subsidiary pacemaker, whether it's the junction, the junctional escape at the region of the AV node, 40 to 60 beats a minute, or whether it's below the level of the junction, so ventricular escape or the His-Purkinje system, 20 to 40 beats a minute. Heart block, complete heart block is the most easiest one of these to understand, but then there's Mobitz 1 and Mobitz 2. Let's do this. So this is a 62-year-old patient with a, I'll just tell you, heart rate of 28 beats a minute at rest and a first-degree block. Who's putting a pacemaker in this patient? Hands. No one? I don't believe you guys. Okay. This is a 40-year-old guy who gets this EKG, resting heart rate of 40 beats a minute. Pacer. Why not? Symptoms, right? Symptoms. When it comes to sinus bradycardia, do not offer patients pacers if they don't have symptoms. The first patient is a marathon runner who does 4 full marathons a year. He's 62. I put him on the treadmill. He does fine, doesn't need a pacer. The second patient is a physician who's an endurance athlete who had an EKG done for other reasons and does not need a pacemaker. So symptoms is when we talk about sinus bradycardia, pay attention to the symptoms. If you send me someone and their resting heart rate 70, doesn't mean they're not symptomatic. They could still be symptomatic. Put them on the treadmill, and they come in with symptoms. Hey, I'm tired, I'm fatigued, I can't do what I want to do. Well, your EKG shows your heart rate 70. Okay, maybe you're fine. Put them on a treadmill, put a Holter on them, tell them to do everything they want to do, and then look at the heart rate. If their peak heart rate's stuck at 90, it's stuck at 100. If their average heart rate's stuck in the 50s, that's a problem. Yeah. So get more data. First degree block. The amount of time it takes for the sinus impulse to go through the AV node down to the level of the ventricle. Anything above 200 milliseconds is abnormal. I've highlighted that what we're measuring there. I think you all know how to do this. So sinus beat comes down, it slows down in the AV node, and then it goes down to the ventricles. Anything over 200 milliseconds is abnormal. This patient had a little bit of a first degree block, I think 270 milliseconds, so you got to watch him closely. This patient had complete heart block on a Holter. So, if you're seeing first degree block, the longer that first degree block gets, so what I'm showing you here are a bunch of P waves with no QRSs, and here are the QRSs bracketing the bunch of P waves. So the longer the first degree block gets, the higher the likelihood that at some point, even if it's intermittent, the top and the bottom are just not going to talk to each other. You're going to end up having complete heart block, and you need a pacemaker. So watch them closely. You might look for symptoms. This is also complete heart block. This patient has also a right bundle branch block. So, this could be issue with the AV node, but this could also be issue below the level of the AV node. And we'll talk about that quickly. Bunch of P waves marching through that I've highlighted. Bunch of QRSs marching through that I've highlighted. If you look closely, the P waves have no correlation to the QRSs. You have way more P waves on the bottom than the QRSs I've highlighted. This is complete heart block. This is AV dissociation, which is a hallmark of complete heart block, meaning the A and the V are not talking to each other at all. They're moving along independently of each other. This patient has an escape, so that's a good thing. That heart rate's about 40 beats a minute, so at least their junction is working. The region of the AV node, the subsidiary pacemaker is working, as opposed to the previous patient I showed you when they just go into complete heart block. They have no escape, and that's very troublesome because then they both need a pacer, but that patient needs a pacer much more urgently. So AV node, just again to highlight,
Junctional escape, 40 to 60 beats a minute. If the AV node fails, if the junction fails, you're relying on a subsidiary pacemaker. You're relying on the His-Purkinje system or the ventricles. Very unreliable, 20 to 40 beats a minute, usually very wide, bizarre-looking QRS. May even need a temporary pacemaker. Right bundle branch block, conduction system abnormality, fairly common in the general population. Left bundle branch block, never good, almost never good. It's usually pathologic. If you see someone with left bundle, get an echo, look for symptoms, make sure they're not passing out. If they're 30 years of age and they come in with a left bundle branch block, that's really weird, and you really wonder what happened. And then they tell you, oh, I passed out. Oh, that's even worse, because why are you passing out? Remember, the left bundle is much, much, much more well insulated. The right bundle is flimsy. We see it commonly in the general population, 1 to 10%. Left bundle, you should not have, it's way less than 1%. So if you see a left bundle, worry about it. This patient passed out. This patient has alternating bundles on a monitor. So the second tracing shows you, I'm going to call it right bundle, although it's not a real EKG, but a right bundle morphology. The bottom shows a left bundle morphology. That means that his Purkinje system is so diseased that alternately the conduction's going down the left bundle causing a right bundle branch block. Other times it's going down the right bundle causing a left bundle branch block. This is a very sick conduction system, not sure why. They're young, they need a pacemaker, and then figure out the workup for why they actually have heart block. Mobitz 1, this is slowing of the conduction in the AV node. So the PR prolongs with each beat until it drops, and then the cycle starts again. Almost always benign. In some elderly patients, I have had this where they're symptomatic and we've had to put in pacemakers, usually driven by something, high vagal tone because they're an endurance athlete, untreated sleep apnea, electrolyte abnormalities, usually driven by something else going on, respiratory distress, nausea, vomiting. And this is because the AV node is a protective mechanism. So what I mean by that is, not every event from the atrium necessarily goes down to the ventricle. That's an evolutionary protective mechanism. Same reason AFib doesn't conduct at 400 beats a minute, because you want to protect the ventricle so you don't end up having a ventricular arrhythmia. Mobitz 2, pathologic, almost always pathologic. So Mobitz 1 is not pathologic. There's the next tip. Mobitz 2 is pathologic. This is conduction loss below the level of the AV node. So it's either the His-Purkinje system, it's either the bundle of His, or it's the bundles itself, the right and the left bundle, or everything on the septum is kind of getting scarred. So you have conduction loss either in the His or the bundles or all of the above. How this looks usually on an EKG is you have a fixed PR interval, and then you have a dropped QRS. And the PR interval prior to the drop QRS doesn't change. The reason that happens is, remember, AV node decrements. So the PR prolongs slowly because the AV node slows down conduction. Everything below the AV node does not have the decremental properties. So if you're bombarding the His-Purkinje system and it's diseased, it doesn't gradually prolong the PR. It does not do that. It just blocks abruptly, and that's usually a bad sign. So you can see this with a narrow QRS, but usually you'll see it with a wide QRS because they also have disease of the bundles below, and that's a problem, and you have to put a pacer. So hopefully I've covered fib flutter, I've covered all 3 SVTs, I've covered VTVF, I've covered idiopathic PVCs, and I've covered bradycardia and heart block.